All right, welcome all. Thank you so much for joining us for the Health Equity Workgroup. I am Chelsea Andrews. I am one of the two engagement coordinators for the MVC Coordinating Center. Today we've got our guest presenters, Carol Gray and Matthias Kirch. They will be joining us from MSHIELD. I hope you all have had a not so crazy weekend. I know a lot of us had some really interesting experiences with the weather in Michigan, but we appreciate you guys all taking the time to join us today. Just a few housekeeping sessions. We are recording the session. We do have questions, time for questions at the end. So if you would like to put them in the chat, you're welcome to do so. If you want to interrupt us at any point, please feel free. But we will have time at the end and we can get to questions from the chat or live. We do also have a post-work group survey, so don't forget to fill that out. Going to get this ready for Carol and Matthias. I don't know which of you are sharing your screen.
I will.
Okay, let me set you as co-presenter. I'm going to spotlight you. Excellent. And then I'm just going to give a quick introduction to you. And once you're ready, you can pull up your screen. All right, so Carol Gray, who is spotlighted right now, leads the overall management, performance, and coordination of the MSHIELD program and coordinating center team. She has extensive experience managing public health research teams, communicating across and coordinating with multiple partnerships, and linking and engaging community-based organizations in Detroit and academic faculty at the University of Michigan. Also joining us today is Matthias Kirch. He develops equity guidelines, advises CQIs on equitable data practices for MSHIELD, and functions as a Statistician Staff Specialist with the Institute for Healthcare Policy and Innovation's Data Methods Hub. He has experience in data management, statistics, survey development, and leading project teams in database analysis. Thank you both again so much for joining us today. Apologies for the chaos this morning. And before you get going, if you want to add anything, you're welcome to. And let me know when you're ready for the poll and I can just get that going.
That sounds great. Thank you so much, Chelsea. Can everybody see my screen? That's great. Awesome. Thank you so much. Really honored to be here. Thank you. We're so grateful to the whole MVC team for making this possible. This is our second time presenting to this Health Equity Work Group, and thank you, just thank you to all of you for making time for this. And yeah, so without further ado, let's get on with it. You don't need to see these because we already had some great introductions given. But I did just want to lift up the beautiful faces of the rest of our team. Really, our whole MSHIELD team collaborates on most of the things that we present. We come from diverse backgrounds and have put a lot of energy and effort into building a team culture that allows everyone to contribute to and contribute their specific expertise to what we share. So you can read about all of these wonderful people on our website, michiganshield.org. And I think now would be a great time to share that first poll, actually, Chelsea, if you don't mind. We just wanted to get a sense of who else is in the room. So there'll be a poll popping up on your screen. If you can just the first question, just answer whichever group you most closely identify with, understanding that you may identify with more than one. But whichever one makes the most sense to you right now today. And we'll just open that maybe for another 30 seconds or so, and then would be amazing if you could just share the results with everybody. Oh, it looks like you have to answer the second one, so that's okay. Go ahead and answer the second one now. We'll put it back up again later, and it will make more sense. Okay.
All right. I think we got most of our answers.
Awesome. And oh, there we go. All right, awesome. So not too many providers or clinicians in the room today, which is interesting. That's great. Mostly quality utilization focused staff, a few data analysts, some hospital health system leadership, and then a few others. We celebrate the others. Thanks everybody for joining us. This is great to know as we kind of lead in. We'll try to tailor some of our comments to y'all. So this is what we are hoping to talk about today. So I'm first just beginning by talking a little bit about who MSHIELD is. We always like to be good ambassadors of the great work that our whole team is doing. Talk a little bit about the framework and definitions that are relevant to our measuring health equity topic. Think about measuring the relevant variables. Matthias will sort of walk us through some established measures, as well as looking at the difference between exploring discrimination and equity in healthcare. And then we'll close with some sort of take-home messages and ways to put these findings into action and hopefully have a great discussion with everyone. I love the slide. So health equity, the term is thrown around a lot as a sort of a buzzword these days, but we do really see it as the future of quality improvement. And it's very important, right, to integrate a lens of health equity into everything we do, but it's very difficult to know where to start, how to do this work right. And it's important to remember that there are multiple right paths. And what's important is to ask ourselves a series of questions when you begin a quality improvement or research project that's focused on equity, to really be attentive to the framing of the questions and the framing of the variables. And to keep in mind that ideally equity-focused research and QI enables action toward achieving health equity rather than solely description of disparities, and approach this work with humility, right? There's no one-size-fits-all approach, but we really do see this as a future, a vision that we can all work toward. So some of you have seen this since many of you are involved in other CQIs, but for those of you who aren't, just a brief description of who MSHIELD is. And I promise I won't spend too much time on this slide, but there's so much great work happening. So MSHIELD stands for Michigan Social Health Interventions to Eliminate Disparities. The CQI portfolio is evolving in ways that better align with the actual drivers of health outcomes. Clinical care accounts for just 20% of patients' health outcomes, but it represents the overwhelming majority of healthcare spending, and we know that we can do better. So the MSHIELD CQI was launched to promote health equity and help achieve optimal health outcomes for all patients. We launched in 2021, so we're fairly young and new to the portfolio, but we do have extensive expertise in working with data involving social determinants of health and health disparities. And we've developed strong ties with community partners across the state who have been engaged in this work for years. And perhaps similarly to MVC, rather than having our own network of providers, which most of the other CQIs have, we support other CQIs and their participating providers to integrate strategies that identify health inequities, address social determinants of health, and work toward better, more equitable outcomes for all patients. So we do this through 3 pillars that underpin our work: data, strategy, and quality, which is the focus of this presentation, social care integration or community partnerships, and then our culture of equity. And our social care integration primary goal is to connect community organizations with other CQIs and their participating providers to address social health needs and to link patients to local resources and care coordination services. Addressing social determinants of health requires systems level change, right? No single entity is equipped to eliminate health inequities. And so we focus on partnership. And our initial work in this space has been in Genesee County. We've been able to screen over 400 bariatric surgery patients through a partnership with the Michigan Bariatric Surgical Collaborative. McLaren Flint Bariatric and Metabolic Institute and the Mid-Michigan Community Health Access Program. It's very exciting work. We continue to partner with other CQIs in other regions, and we're always looking for opportunities to broaden our work across the state. And then our culture of equity work, this pillar supports CQIs to explore ways to integrate anti-racism into their work. We developed a curriculum to grow each CQI's knowledge of health equity and anti-racism, and to identify opportunities to incorporate a health equity and anti-racist approach into the work of each CQI. And to do this, every CQI has identified a health equity champion to commit to about 5 hours per month of critical reflection, action labs, and self-guided tasks. And that's been really successful so far. We're excited for that to continue to develop, and actually planning for a data-focused presentation next month. So stay tuned for that. And you can read more about all this work on our website. But this is not the focus of today's presentation. We are really going to try to focus on data strategy and quality. And to support CQIs to integrate a health equity approach into analyzing, interpreting, and disseminating data from a health equity perspective, we co-developed what we're calling a Measuring Health Equity Roadshow. And this presentation is a shortened version of that, that eventually will be turned into a guide, sort of a best practices guide and a toolkit that will be disseminated across the portfolio, and will then in turn be shared with other quality utilization staff across the state and providers through their connections with the CQIs. So let's get into the framework and definitions that sort of underpin this work, and want to present a sort of example question or case study related to patients with diabetes. So initial analysis across hospitals found a difference by race in which patients were getting continuous glucose monitors and the newer classes of effective diabetes medications. And so the question becomes, how do we start? We've identified this outcome, this disparity, but how do we unpack that from a health equity research and action framework? What's driving that disparity, right? And there's a few different ways to think about this. Is it clinician bias, right? Are there racist doctors out there that are just not paying attention to who they're prescribing? Is there a difference by type of insurance? Are there different hospitals that have different access to resources, and that's what's driving this disparity? So it's not always clear exactly what to do about these disparities that are noticed by the analysis that takes place at the CQIs. And so it's important to ask a series of questions, and important to talk to folks across the institution to really understand what's going on. We look to Donna Bedian to provide a structure, process, and outcome framework. And this is probably very well known across this group, but basically Donna Bedian advanced the idea that there are multiple ways to look at quality. And when you're looking at any kind of quality improvement project, you want to pay attention to the structural measures, the process measures, and the outcome measures. And I'll go into a little bit more detail in a couple of slides, but I love this quote. Ultimately, the secret of quality is love. If you have love, you can then work backward to monitor and improve the system. And so starting from this place of love and place of care to support really the dignity of all patients is something that is important to keep central. So a couple of important definitions before we go too much further. I really find it important to distinguish the difference between interpersonal racism and discrimination and structural racism and discrimination. Often when we hear the term racism, the mind goes to awful imagery of direct, visible harm to people of color, or perhaps an internalized feeling that when racism is identified, there must be a single person or people to blame. But in fact, there are multiple complex ways that racism is interlaced with our societies and institutions, policies and practices. And just as no one single entity can eliminate health disparities, no single person or entity is responsible entirely for racism. And Ibram X. Kendi discusses this in his book, How to Be an Anti-Racist. Racism can be thought of as a simple description rather than a pejorative term. And he goes on to say that we either choose to align with racist hierarchies or we do not. And so thinking of it this way helps us see that there are choices and decisions that can be made along the way to begin the difficult work of dismantling the structures that lead to some of these health disparities. And another way to think about this, which Matthias will go into a little bit more detail about, is race is fictional, but racism is real. And so how can we look at ways to measure racism rather than looking at race as a biological variable, for example? So going back to Donna Median, his structure, process, outcome framework is here applied to our earlier examples, some of the potential drivers and potential solutions identified in each category. And I won't read everything on this slide, but since we just described structural and interpersonal racism, we might also term process as interpersonal. So, a structural driver of the disparity previously, again, might be a hospital with fewer resources. An interpersonal or a process-based driver might be a clinician implicit bias on who can use the new devices. And then, the outcome is what we've already seen. What stands out to us here is that the potential solutions to each type of measure are actually all structural, right? So the solution is not don't be racist. Rather, it's more complex and it's also simpler than that. So I think that's what I really want to sort of lift up on this slide. And so now I'm actually going to turn it over to Matthias to go a little bit more in depth with what this looks like when we start unpacking, measuring the relevant variables. So Matthias, please.
Thank you. All right, you can move to the next slide.
Mm-hmm.
All right, so we're going to be talking about how to actually measure sociodemographic variables. And this is something that I'm sure everyone is familiar with. You've filled out a million forms about your own, who you are. But these things are actually often changing, and that's okay. I like to think about them as evolving as we get to know social definitions a little bit better and how they affect people. So let's go ahead. So when you think about what variables that you need to focus on in a clinic or in a system, really the most important thing is to look at your patient population, because you're going to know best who is in your patient population and what, like, subgroups of people might not be receiving the same care as others. Because in the end, this is what disparities is all about. A disparity is that even if the outcomes overall are improving for people, if there's a group of people for whom they're getting worse or they're not improving, that's where you don't have equity. And so really trying to figure out what groups might be important pieces of your population. Is that elderly patients? Is it, a particular type of worker? Is it immigrants? Is it people based on their gender identity? All of these are possible groups who might not be receiving the same quality of care. Okay, so the first part of collecting data that we often talk about is race, ethnicity, and language, which can also be called real data. As Carol mentioned, always we need to think about treating race as a social marker. So we're really, when we're asking about race, we're talking about a social category. There is, no biological difference between people based on what we call race. These categories are things that have changed over time and continue to change as people identify themselves. So we're really talking about asking people to identify a racial group or an ethnic group that they're a part of to find examples of structural racism and discrimination. All right, so you probably have seen this version that's on the left of your screen before. These are the Office of Management and Budget. Like, I think these were developed in 1997, where they ask basically two questions. What's your ethnicity? Is it Hispanic or not Hispanic? And then what's your race? And you can select one or more. They are actually in the process right now of moving to a more integrated system, a one question system. I haven't actually seen an example of it, but I put an example of what I think this could look like. And I think this is the direction a lot of places are moving. So you'll notice a few things about here. It doesn't say anything about race or ethnicity necessarily in the question. You don't even necessarily have to. You're just talking about how do you identify. And you allow people to check all that apply to them here. Not necessarily always done, but one thing I think is important and you can do is to put the categories in alphabetical order instead of listing them by any particular other order, because this way it helps people look down the list, find the right one, but you're not, prioritizing any certain population by putting them at the top of the list. There are a few other things they're possibly in the process of changing. The term American Indian has been used in the past, but we know that comes from some problematic history. And it seems like Indigenous American is a term that more people are, again, these could change and you really need to talk to your communities that you're a part of to figure out what's best here, but just paying attention to like how people identify themselves is really important. Another big difference is instead of listing, as it said before, some other race or other, we all know that othering people is never a great thing. So instead of saying other, like you're just something else, you can put a simple statement like not listed here and then let people fill in, what's not listed. That will give them the space to identify in a way that makes sense. And then also offering people the chance to not answer if they would rather not. Another thing I've seen sometimes is to offer a write-in after each of these categories. So, Asian, for instance, Asia is a huge continent. Allowing people to self-identify how they identify within each of these categories is another one. Or, for instance, asking for tribal affiliation for someone who's an Indigenous American. These are all ways to kind of offer even more self-identification to allow people to really give you a sense of who you are and who's in your population. So language is another one that you might want to ask. You might ask people about what their English proficiency is. You can also ask about what languages they speak at home. Ask whether they prefer a certain language to be conducting their healthcare in. You can also ask, not ask, I think some other practices here are to make sure that any materials that you're providing, any forms, are either offered in multiple languages or that you at least have a place where people who don't speak English as their first language can find a place to, get some more information in their original language. Another thing we can do is ask about health literacy. There's a lot of single item or multiple item health literacy questions. This might just give you a sense about like the reading level that your population is at, if they're able to, review complex documents or things like that. I think that really kind of thinking about who your population here is important because language encompasses a lot more than just like, what your first language is or what language you speak at home. You might even want to consider things like having audio versions of things instead of read for people who either have difficulty reading because of a sight issue or because of their low literacy, so that they could listen to the options instead. So just a lot of things to consider. Again, I really want people to kind of customize the way that they ask questions to fit the population that you're dealing with. Another category is looking at sexual orientation and gender identity, or SOGI data. And again, these are categories that really talking to populations is really important and letting people self-identify. So for sexual orientation, this is who people are attracted to. So you might say, do you think of yourself as straight or heterosexual, lesbian, gay, homosexual, bisexual, something else, or, don't know, or questioning and choose not to disclose. Offering options like this. Again, why are you asking this question? Is it because you want to make sure populations are getting equal access? Might also want to provide that information here to people, because some of this, it might be considered, kind of private information that someone doesn't necessarily want on all their forms. And if you say, this is only collected so that we can make sure that all populations are receiving equal care, that might help people to feel more comfortable answering the question. In terms of gender identity, moving away from just offering two categories, male or female, and allowing people to self-identify, this list offers some options that you can include, like trans male or trans man, trans female, trans woman, gender queer, or gender not listed. You can also at least offer a third option, which is the gender not listed, right? So you could say male or female or gender not listed. You can ask someone if they identify as transgender. You can also ask, what sex were you assigned at birth? Most people, I believe, do get assigned a sex at birth. I know that there is a growing movement in the intersex community to allow those markers to maybe even appear on birth certificates and things like that. So just being aware that there are multiple ways of asking these questions, and also understanding what you're trying to get at here. So especially in healthcare, right? I mean, if you just offer two options, people might not know what you're trying to get at. Do you want to know what someone was assigned at birth because you want to understand what body parts they have or may have had in the past? Or are you really interested in knowing someone's pronouns? And in that case, you should just ask, well, what are your pronouns? And then people can tell you what their pronouns are, and those are what you can use to refer to them as. All right, some of the other things that we can collect are socioeconomic status. This can be asked in a few different ways. So you can ask someone about their income, about wealth, which can come in a number of forms, or educational attainment. Often income and educational attainment, at least, are pretty highly correlated on a lot of health outcomes. It makes a lot of sense that these things are correlated. We know that there is not equal health for people across the financial spectrum. And so really understanding those disparities is really important. So this is one way to do it. Another thing to pay attention to is often, even if we don't ask these particular questions, we might have some other marker like somebody's address. And if you have their address, you can, if you're trying to understand, are there disparities in how people are, receiving care, we can look at things like zip code, or we can look at things like neighborhood and figure out if people from certain areas where they live are receiving different kinds of care, having different outcomes. And that can give you some sense about whether the care is reaching all parts of the community in the same way. So I wanted to talk a little bit more about the individual level versus area level measures. And I was wondering, Chelsea, can you pull up the second part of that results again?
Yeah, do you want to relaunch the poll, or would you like to look at that?
No, I think we can just look
Okay.
at what people said.
Okay, definitely.
All right, so if you scroll down to the bottom here, I just thought it would be interesting to ask what type of data you think is best. And I think we have a real mix here. We have the medical record abstraction, we have the patient and provider information, population survey data, administrative claims later. So which of these is best? Well, the answer is there's not really a best, right? They all provide a little bit of different information. For instance, if you tried to ask a patient, if you asked yourself, how many times have you been to the doctor in the last 12 months? I mean, maybe you know that answer, but maybe you don't. So here, like a medical record abstraction is going to be a much better measure of that than just simply asking somebody, but asking people about, have you experienced discrimination in a doctor's office? That is not going to be found from anywhere except from asking people directly, either through interviews or through a survey. We also have information at different levels here, right? So you have the individual level data, which is maybe a provider level data, interactions that happen at the provider level. This is information about your own living experience. information about how you identify. These are all important things. And really all of these should be asked of the person directly, any way that they identify themselves. And then you can also get information that's on an individual level, but from a health system, for instance, like I was saying, the number of visits and things like that, still on the individual level. And we can look at that with the characteristics of a person. But we might want to also look at differences between hospitals and clinics. So like the example that Carol was showing before about how maybe there are hospitals or clinics that serve different populations of people and they have different levels of resource. And that could really impact the downstream care that they receive and then the health outcomes. And then finally, looking at regions or state or federal level differences. Policies affect people really differently. State level policies, for instance, like the Medicaid and how that is applied is going to have a big impact on the kind of care people can receive, especially people at lower income. So understanding all these different levels of data and that we kind of need it all, but you have to figure out which part is going to answer the question that you want to get at. Again, I keep emphasizing that we really want to talk about, if we're talking about how people identify, you want to look at the individual level. You want to ask somebody themselves, who are you? How do you identify? Understand that these things can even change over time, and that's okay, as long as people are self-identifying whatever that is for them. And then looking at some of the other information as you move out from that model. So we can go ahead. Okay, so we talked a little bit about measures of discrimination versus measures of equity. These can be a little tricky, and I think that there has been definitely some work in here. So when we're talking about discrimination, we're talking about specific things that people have experienced that make them feel like they are not getting the best care that they could get, right? So these, you might say, have you experienced discrimination in a healthcare setting? And people can say yes or no. And oftentimes you follow it up, well, why do you think you were treated differently? And people usually have a good sense of why they think they were treated differently, because of my age, because of my disability, because of my race. So these are really important measures to get at what people are experiencing and how they're experiencing the system. But when you're talking about health equity, you're really talking about how outcomes look at a system level. So you might say, okay, we want to know the number of people who had regular primary care visits across by different kind of characteristics, by age, by gender, by race, ethnicity. These are things that you sum at the hospital or the clinic level, and then you look at over different groups, because they'll give you a sense that there's a big difference between how different groups are seeing the information. So again, here where we're talking about the structure, process, and outcomes, the process, the interpersonal things are these self-reported measures of discrimination. The structure piece is that you're getting different level outcomes for different groups of people. And that could be because there's interpersonal discrimination, but it could be for other reasons as well. Okay, there was still some animations left in there, but all right. So key concepts in here is, first, don't consider race as a biological variable. And I say this, and maybe this seems obvious to people, but this still comes up in medical journals to this day, where people say, okay, well, we have this study where, there's a different outcome for this racial group, and we're going to say, well, they must be biologically different. We're really moving away from that. That is not an appropriate approach. And it's not an appropriate approach either to use race as a category to predict medical outcomes. Race is a social category that impacts the way people experience systems and interact in society. And that's really what it's showing us here. One way to get at how these differences might look is to look at stratified analysis. So instead of comparing just across groups or just looking at the entire population, look at each group individually and see what their outcomes look like. I know a lot of times there might be smaller numbers of people in some groups, and that's okay. I think especially in quality and equity focused research, we can look at some smaller groups. I mean, you might not be able to publish data on smaller groups, but I think it's still important to realize if people who have a different identity are having really different outcomes, are having really different impressions of how the care was going. That's really important for you to note as a quality improvement specialist. And another thing to really think about is this intersectionality of race and ethnicity, gender and class. What can this look like? Well, this is, again, break down this stratified analysis, but look at it even more deeply by, okay, within people who identify as Black, are there differences between men and women? Are there differences for people who have a gender identity that is not men or women? Is there a difference for people who make less money? Is there a difference for people who have less education? Because these differences will really help you figure out where some of these structural issues are coming up that are affecting the outcomes that patients are experiencing. All right.
Okay, thank you so much, Matthias. So we're getting toward the end here, but wanted to just point out a couple of ways that we think about putting findings into action and then open it up for a discussion. And should have said this earlier, but please do at any point, go ahead and unmute and interrupt or put any questions in the chat, and we'll be happy to address those when we get to the discussion. So thank you so much. Oh, it's so funny. These animations just stay in here. Here we go. Okay, so we'll keep this brief because we do want to get to that discussion, but just some take-home messages for you, sort of building on that summary that Matthias gave. We heard that it's important to focus on who is experiencing the health disparities, right? To not make assumptions rather than taking what others have done and assuming your population is facing those same disparities. Think about your specific area of care and apply the framework and ask the questions to understand your population, and then stratify by the key relevant socio-demographic variables that apply to your area of care. To consider how these disparities are driven by factors at multiple levels, right? There's a lot happening in this field, as Matthias said. It's really changing pretty quickly. And it's important to stay aware of the factors that you might have some agency and power over, and factors that are more long-term, that are bigger. And it's helpful to do that at the beginning of any project, right? To keep it manageable and avoid being crushed under the existential weight of the problem and how many ways this really impacts people's lives. But thinking about, whether you're going to focus on the individual level, at the health system level, or at the regional, state, federal level, when you're thinking about potential solutions to the drivers of the disparities that you're seeing in your data. And then this final step about taking action, this is something that I think we can all do, whether we touch data every day or not, just to simply consider equity as a critical piece of every project. It's a start, right, toward building the world where we all belong, and where we can all achieve our greatest health potential, regardless of social identifiable barriers. That is the world that I want to live in, right? Where we're all capable of achieving our greatest health potential. So considering equity as a key metric in research and a critical goal of quality improvement will help push us toward that world. And that is all we have. We are really excited to hear from you. As I said, this is a road show, and we're developing this for multiple audiences. So if you have feedback on other elements that you'd like to see in the future, or other audiences that you'd like us to bring this road show to, we would be very open to hearing the feedback and other ideas for our team. But thank you so much for your attention today.
Thank you so much, Carol and Matthias. I really appreciate it. Does anyone have any questions? And you're always welcome to put it in the chat if you'd like us to read it out loud, or if you don't have access to your microphone. I have one question. In the past, I've worked with like birth certificate data and other types of data reporting on like community index or patient identifiers. Curious how you guys how you see this data or these types of data forms being more equitable across, EMR, EHR, because, like you said, these are more equitably focused, but how can we integrate and implement equal ones across different EMRs and health systems, as that's going to make a big difference on how data is tracked and abstracted to make sure that we have consistency across these different platforms.
That's a great question, Chelsea. Really appreciate it. And I'm sure Matthias will have some insights here, but just to acknowledge, we know that if the data isn't correct when it enters the EMR, it's not, if that's the only way that the CQI is getting that information, there's really very little that you can do about that, right? That that might be a quality improvement project, right? Like that might be something to look at of how is the data really getting in there, and are there ways to sort of continue to move upstream and ask at which point is it appropriate or possible to create an intervention to improve the way that the data is collected, so that when the CQI finally sees it, months later, they're not just seeing a bunch of unknowns in their spreadsheet, right? Which is, it's very hard to do something with that. But Matthias, please.
Yeah, I think this is a great question because, I come from a background in quantitative data, which I'm sure some of the other of you do. And, we kind of were shown this shiny world. If we can just find data sources, we can figure out everything. But I think what I'm learning as I, go further into this is that there is a real benefit to kind of like learning about things qualitatively as well. And so even sometimes what that can look like is qualitatively assessing your data sources, right? So for instance, if you have information in the EHR, say about race and ethnicity, it might be really important to start asking some people around who are part of either inputting this data or maintaining the system. Well, what do you know about this? Where does this data come from? I spent quite a lot of time talking to multiple people across like Michigan medicine, trying to find out this exact question. And I found some really interesting things. Like, for instance, babies who are born into the hospital system are automatically assigned the race of their mother, which might be right, but it also might not be. It might not be complete data. And if you never went into your health record and checked it and verified that that was the correct identity for your child, they might be misrepresented in all their data. So these are the kind of things that are really important to understand. And so even if the data itself might have some questions, I think that we can use information that we gain from these type of interviews and learning about how the data systems are put together in our description of this data. So this is the data. Here's some caveats about it, but like, this is what we know right now.
That's great insight. Thank you. There was a question in the chat, or I'm going to put this on gallery view. I do have you guys highlighted, but for this next question, is anyone on the call participating in the Blue Cross Blue Shield of Michigan's Social Determinants of Health Standardized Data Collection Initiative with MyHIN? Welcome anyone to share their experiences with this, or if you'd like to, you can just do the little hand raise with the Zoom options and the reactions, so we could get a assessment of who's participating that, if anyone is on the call today. Doesn't look like anybody is. It's also possible we don't have a whole lot of our coordinators on today.
So I don't have experience with this yet, but I am meeting with MyHIN in the next couple of weeks. And it's one of the questions, like we're trying to kind of talk between MSHIELD and MyHIN to understand how they're asking versus how we're asking, so we can do some coordination here. So it's something we definitely hope that we can report back to the CQIs and other leaders about in the future.
Yeah, thank you, Matthias. I mean, MSHIELD has been partnered with this effort for since our genesis. But as you can imagine, it's very complex, right, to roll out any kind of standard data collection across the state. And there have been fits and starts along the way. But we're so grateful to have Matthias on board now as a dedicated staff member to kind of think about ways that we can improve our work with MyHan, and then as a result, maybe even share any insights that we're able to glean with the CQI portfolio, and in return, the providers that participate with them. And I do see that in the chat, My Michigan Health looks like they've just signed the use case for sending SDOH data to MyHan, so that's great to hear. And we also look forward to what this will mean for health equity in all of the communities in Michigan. So thank you for that question, Jana.
Thank you, Hannah, for sharing that. I have another question in the chat from Irene. Irene asked, do you feel there's a better response to obtaining the data by actively asking individuals or passively by asking patients to complete a short questionnaire at the time of registration?
I think this is a great question. And I think that the answer is it depends. And why I say that is because I think it takes really well-trained interviewers to be able to gain the trust of people that they're asking about. So if you have someone who is really trained in sort of like behavioral health and things like that, you might be able to get better information by asking someone these questions, and that way you can clarify with them what you're trying to get at. But the truth of the matter is that most people who are maybe at like a front desk receptionist type are not trained to do this, right? And what ends up happening, actually, if you leave it up to people who are not fully trained and not fully comfortable, is that they might not even ask the questions. And what we get then is people doing an eyeball. Oh, well, you look like you're white, so I'm going to mark that, because I don't want to ask you what your race is, because that will make me feel silly. So I mean, you have to think about real people in these situations. So I think, unless you can really make sure that you have like really well-trained people, which I know that there's some clinics who do and really make a point of this, that letting people self-identify in a form is probably going to get you the better information.
And actually, I'm curious, Matthias, do you think that there's an advantage to doing a both and kind of situation? So could you maybe have a form and also potentially have people ask the question and then compare or, unite that data somehow?
Yeah, I mean, I think that you definitely could, right? You could hand people, a form as they come in and have them fill it out, and then, have someone who is trained, like when they come back to a room, to discuss it with them. Mm-hmm. And again, some of these things that you might want to know might be kind of sensitive. So again, you don't want to maybe be asking that at the front desk where everyone can overhear. Like, you want to make sure to really protect patient privacy, even on these type of questions when you're asking about people's identities. Mm-hmm. And I think that another advantage, I guess, of having someone who's trained is they can give a little more background in why they're asking this information. You can also have, again, it depends on the type of clinic you have, but if you have a diverse staff of people who are kind of asking these questions, they might feel more connected. Say, okay, you're someone who seems like you might understand my community a little bit better, and you're asking me these questions. I feel more comfortable talking to you than I would even filling out a form. So I think you can definitely improve the process, but it does take training of the staff as well.
Is there anyone who's attending today who could speak to any related training that's going on at their institution or their organization, or any programs that have been implemented to address this equity lens?
This is Kelly from Moxie. I can share that we have a handout, like a one-page resource that we make available to our practices that talks about the rationale behind why we want this data, and actually gives some scripting so that if it is maybe someone on the phone who's registering the patient for the first time, who's filling out information and asking these questions, there's some scripting available so that those folks who maybe aren't used to this and maybe aren't trained in how to do it can just kind of say what the scripting says or put it into their own words. And it explains, we want this information so that we can make sure that everyone gets equitable care. We haven't done any sort of in-person trainings or anything like that, but we do at least have that written resource that we make available.
That's great to hear, Callie. And yeah, I think something like that is pretty, I would think would be pretty effective and economical, right? Like training is expensive, and sometimes rolling that out is certainly across a health system can be prohibitive. I mean, it can feel pretty overwhelming. And so starting with sharing that information, some simple things, ways to just increase the understanding of why this information is being asked for and help people who are asking those questions know what to say. That sounds like a great solution. Appreciate that.
Are there any others who can speak to their experiences at their organization? Or any other questions for Carol or Matthias? All right. Well, really appreciate you guys taking the time to speak about this with us today. It is a very important topic, and we're really hoping that there's more conversations across, MSHIELD and all the other CQIs and the MVC members to increase equity across the health systems and health organizations. Right. Well, if no more questions, I'm going to share the final closing slides and we can close out today's work group. Thanks you again. We have some upcoming work groups for preoperative testing and diabetes in March. We have some guest speakers with our preoperative testing work group. It'll be the first for this year. This will be presented by MVC's very own director, Dr. Hari Nathan, and our diabetes work group on March 21st. We have guest presenter Ann Andrews, who is a senior program manager from National Kidney Foundation of Michigan. The link to register for the work groups is going to be included in the slides that will be sent out following the conclusion of today's work group. If you have any questions or you want to connect with Matthias or Carol, or if you have any suggested topics for the MVC work groups, you are welcome to send them to our email or in the follow-up survey that you'll receive in that email. So thank you all again for joining us today. Truly appreciate you taking the time out of your day to join the discussion. We look forward to seeing you at future work groups, and thank you, Carol and Matthias. Bye, everybody.
Thank you. Bye.